Welcome to CSIS Online. The way we bring you events is changing, but we'll still present live analysis and award-winning digital media from our Dracopolis Ideas Lab. All on your time, live or on demand. This is CSIS Online.
Good morning. I'm Catherine Bliss, Senior Fellow at the CSIS Global Health Policy Center, where I direct our work on immunizations and health systems resilience. Welcome to this session on the state of global immunization programs as we move further into a third year of COVID-19. The past 2 decades have really been characterized by significant improvements, gains, in global immunization coverage in many parts of the world, particularly in low and lower middle income countries. And the past year has been characterized by the increased global distribution of COVID-19 vaccines as well. But since 2020, gaps in routine immunizations have widened in high, middle, and low-income countries alike, due in part to the massive diversion of resources to outbreak response starting in March of 2020, and also due to lockdowns and social distancing measures. Today, we'll be talking about what it will take to close those gaps in routine programs in an equitable manner, ensuring that the most difficult to reach populations, be they migrants and refugees, adults and adolescent girls, or children living in remote or underserved communities, can access immunization services in the same way others can. Today's event takes place during World Immunization Week. And as many of you know, World Immunization Week celebrated annually in the last week of April. It serves to raise awareness about vaccine-preventable diseases, generate advocacy to support international immunization programs, stimulate political will to invest greater financial and human resources into vaccination campaigns as well. And I believe that this year marks the 10th anniversary of the World Health Assembly's endorsement of World Immunization Week, formalizing the activities that many countries around the world had been undertaking at different times in kind of an ad hoc manner prior to 2012. Now, the theme this year is a long life for all. And in recent months, CSIS has been working on issues related to equity in immunization services, with an emphasis on addressing gender-related barriers to access, extending immunizations to populations in fragile or conflict-affected settings, and considering how programs can expand in a sustainable way to better include adolescents and adults without sacrificing the focus on children. And so we thought it would be relevant to this year's theme to host a discussion with a group of experts who bring considerable experience with program design, program implementation, and program oversight to their work. They also bring deep perspective with local level implementation, international development assistance and support, and multilateral agency coordination to their efforts to extend immunization services and really ensure a long life for all. I'm really pleased to welcome Rebecca Fields, Technical Lead for Immunization with USAID's Momentum, Routine Immunization Transformation and Equity Project, and she is based in Arlington, Virginia. I'm also pleased to welcome Mireille Lembwadio, Global Vaccination Coordinator at the International Organization on Migration in Geneva, and Cathy Ndiaye, Senior Technical Advisor at the Center for Vaccine Innovation and Access at PATH, based in Dakar, Senegal. So, let's get started. Now, the World Immunization Week theme of long life for all really encompasses a focus on equity in access to immunizations that has been at the heart of so much discussion related to vaccines and health services under COVID-19. It emphasizes the importance of ensuring broad geographic distribution of vaccines to high, middle, and lower income countries. And it also emphasizes, I think, the necessity of ensuring access for people living in remote settings or hard to reach population, and reminds us of the relevance of immunizations for people of all ages across the life course, that is children, adolescents, and adults. So Rebecca, let me start with you. In the countries where you are working with JSI and the Momentum Project, to what extent have the social and economic disruptions of the pandemic accentuated gender-related barriers to vaccine deliveries, and including COVID-19 deliveries over the past year plus months. What have you seen?
Well, thank you so much for that question. And I think it's important to recognize that the gender barriers to immunization existed prior to the pandemic itself, but really were under-recognized. We had long looked mostly at sex disaggregated data around who was being vaccinated and didn't see big differentials between the number of girls and boys being vaccinated. And so the gender barriers for anybody to get vaccinated really had not been very well recognized. In the lead up to the development of the Immunization Agenda 2030, IA 2030, as well as the Gavi 5.0 strategic plan for 5 years, much more attention was devoted to really recognizing what some of those gender barriers are and how they play out in terms of limiting access and utilization of immunization services. So again, this kind of predated a little bit the pandemic, but as the pandemic has progressed, we've actually had the opportunities, in fact, to develop a far richer understanding of what those barriers are and how they affect immunization, both for COVID and for routine immunization, routine childhood immunization. And, fortunately, we've seen some greater resources devoted to understanding what those barriers are and also devoted to going into efforts to address them. So those barriers, those standard sort of barriers that pre-existed before the pandemic included limited mobility for women to be able to access services, especially if those services were not offered at convenient times or places. Other barriers included, certainly a very important one, is limited autonomy by caregivers who tend to be female, tend to be the mothers, not exclusively, but that's commonly the case for childhood vaccination. Limited autonomy on the part of those mothers as to being able to access services and actually accessing the resources to be able to take the child for vaccination. Taking the child for vaccination means leaving behind temporarily some of the other responsibilities, household duties, income generation activities that mothers are also responsible for. And in fact, it has been through some surveys that have been conducted in connection with COVID vaccination during this past year that we've come to recognize just how important it is to ensure that in communicating about vaccination, we don't communicate just with the mothers, but that we communicate with the fathers, the male partners, the mothers-in-law, the grandparents, and so forth, because they have at least as much influence as the mothers in determining whether the mother can, in fact, take that child for vaccination. We also have to recognize that some of the gender barriers, excuse me, some of the gender barriers that are faced in immunization, affect the health workers themselves. 70% of health workers, frontline health workers, are female. They have their own issues about their family responsibilities, their ability to move about. And of course, all of this has been exacerbated. All of these barriers have been exacerbated by the pandemic. This has changed over time. Right? I mean, at the start of the pandemic, we were seeing very severe lockdowns, severe cuts to transportation. Services themselves were severely disrupted. Fortunately for immunization, there has been somewhat of a rebound, a relatively rapid rebound for restoring immunization services, but not necessarily making up for the disruptions to services that extended over several months in 2020. That means we have a lot of children now who are unprotected from vaccine preventable diseases and who we urgently need to look towards and help address their needs. But we also saw with the pandemic, with regard to gender-related barriers, that women were really acutely affected in terms of their daily lives. They suffered a lot of severe secondary effects, loss of income, loss of jobs, taking on additional responsibility for childcare as schools were shut. We also saw an increase in gender violence. All of this has been exacerbated by some of the changes to the services themselves, including a shift towards really emphasizing COVID vaccination as being critical, and sometimes diverting resources away from routine immunization or other essential services in order to make COVID vaccination, raise coverage for COVID vaccination as quickly as possible. A couple of other things that we see with regard to the effects of the pandemic have to do with the specific circumstances that the COVID virus contributes to. We know that pregnant and lactating women have particularly elevated needs for COVID vaccination. But we also know that even as women often suffer from relatively limited access to accurate information, the rumor mill is still very active. And the circulation of misinformation and even deliberate disinformation is constant and needs to be dealt with on a constant basis. And we need to use a variety of channels for really trying to counter that misinformation, recognizing that that interpersonal communication is extremely powerful. The last thing I would just say here is that with regard to COVID vaccination itself, initially, we were seeing in many countries that the proportion of COVID vaccine doses that were going to women was much lower than the proportion going to men. And so this has really required a lot of work to look at the sex disaggregated data about COVID vaccination to see who really is getting vaccinated and who is not. And then, importantly, talking with women, finding out from them, hearing their voices as to what are the impediments that they are facing and what could be done to try to improve the situation. And just as one example of where that has played out very well, we see that in South Sudan, back last summer in mid-2021, only about 26% of COVID vaccine doses were being administered to women. You know, we would expect that to be more about 50%. It was only about 26%. After implementing a combination of activities of research with women, of developing specific interventions to try to reach them, we've seen that over the course of about 6 months, that proportion has increased from about 26% to about 48%. So this really gives us a sense that there are things that can be done. This is not an insurmountable issue. There are things that need to be done, but we need to hear from women as to what the issues are that they are facing and what they view as the most important interventions that can help them in accessing both routine immunization for their children as well as COVID vaccination for themselves and their families.
Great, thank you. I mean, it really sounds like that last example that you gave. I mean, the issue of awareness, of tracking the data and finding out what women themselves felt were some of the challenges to, you know, really improving that 25% up to 50%, you know, really led to a redoubled effort to conduct outreach and really was able to move that number forward. That's a really inspiring story to hear. Mireille, I want to turn to you for a second. You know, Rebecca at the outset talked about both the Gavi policy on gender and some of the focus within Immunization Agenda 2030 and Gavi 5.0 in terms of particularly, you know, reaching difficult and hard to reach populations. And Gavi, of course, also has the policy on fragility, emergencies, and refugees. That may not be the right order that I'm saying it, but has had that policy as well. And I just wanted to ask you to say a little bit kind of about the state of efforts in terms of reaching migrant and refugee populations with immunizations before the pandemic, and you know, to ask you to say, you know, what how the pandemic has really shaped outreach to populations on the move during a period of health crisis and, you know, lockdowns and the kind of social distancing that we really saw particularly in 2020 and early 2021. And if you could just say a bit about why it can be challenging to ensure that these communities which, you know, may be in a different nation than their home nation or, you know, in between communities, why is it particularly challenging to ensure that they have equal access to immunization services, and what has IOM in particular learned during the pandemic?
Thank you so much, Katherine. Good morning. So we could really see that while the COVID-19 pandemic had affected everyone in the world, the response and related measures had initially created additional levels of exclusion of migrants, but also displaced populations and refugees. With regard to access to basic healthcare services, including vaccination for COVID-19 when it became available, of course, but also other antigens as routine services were highly disrupted. So while pre-pandemic, we were seeing a bit of progress in the consideration of migrants, displaced populations and refugees into the different strategies, but also the implementation plan, as well as in actual targets and forecasts, the pandemic created a rupture of these steps. And we then witnessed a serious step back, requiring efforts and engagement to design and implement strategies and plans with host ministries of health, but also migration, foreign affairs, interiors, and others to reach these groups while ensuring their rights to health and protections are preserved. So the challenge is to ensure these communities have equal access to immunization services related to COVID-19. As we know, most countries of the world initially prioritize healthcare workers, elderly persons, and people with comorbidities in what we call the National Deployment and Vaccination Plan. And then they extended the eligibility criteria to additional prioritized groups, but primarily for the national citizens, leaving out vulnerable populations such as migrants, IDPs, and also in many cases refugees that are all equally in need to be catered for. This was initially triggered by the limited availability of supply when the vaccines became available, and then by the limited funding for operationalization of the different plans and their deployment, and as well as distribution down to the last mile, which was obliging tough and discriminatory decisions to be made at very high level of the political engagements. But through different monitoring and observatory mechanisms, we noted also that while some of the plans could mention in theory the inclusion of vulnerable groups, there was no translation in practice when it came to implementation of those plans. And this, however, helped us shape and tailor advocacy and political will strategies and related interventions. Nevertheless, beyond the target population prioritization that we easily mention as a key barrier, many others can be attributed to the challenge in ensuring migrants, IDPs, and refugees have access to immunization services. And these definitely apply to COVID-19, but also to echo Rebecca, I would say these were also known as part of routine immunization services, even pre-pandemic, and definitely with the pandemic that has disrupted all these services. So we mainly talk about barriers related to administrative processes and policies. In some countries, for example, you have certain laws and regulations that simply and really openly really ignore and bar some categories of migrants from having access to public health services. Vaccines are in some cases reserved only for nationals, and especially when it comes to limited supply, as we have experienced with the COVID-19 pandemic, for example. We also have the issue of specific documents that might be required from the beneficiary. In some countries, fortunately, we have countries that accept any form of ID, valid or not, expired or not, and from any country, only to verify the name and the identity. But then we have other countries that would require specific type of documents, for example, residencies, insurance cards, which really constitute a higher barrier for the beneficiaries. But those documents sometimes are accepted even if they've expired. And then we have countries where documents that have to be presented have to be valid and not expired. We also see a blurry, or let's say an absence of firewall between health and immigration authorities. In some countries, health workers are required to report to immigration authorities. Migrants that are coming for health services, but that are in irregular situation, which really leads for the beneficiary, for the migrants or people in vulnerable situations, to the fear of being arrested or deported. And then we also face the issue of registration that could be required to be done through different systems and often online prior to vaccination, which is really implying another barriers for the beneficiary because of technological requirements, because of the language barrier as well. Again, fear of being tracked through these systems and then arrested or deported. The migrants are also facing financial barriers in some instances because while the vaccine is free in most countries for people that are registered in national schemes or health insurance systems, in others it is really unclear the line on whether or not they should pay for it or whether or not they should be enrolled before that into those different schemes. They face, as I mentioned, technical barriers like lack of internet connectivity, lack of access to information in the right language, and also mistrust is something that is really clear among the different communities because of linguistic but also cultural barriers that we can have a very long list around it and that we might have referred to all of us during this pandemic especially. We also see a lot of logistical hurdles for vaccines that are not reaching the last mile, like I mentioned, but also in terms of geographies, you mentioned the hard to reach areas, but also in urban areas, people that are really hard to access. And then also weather conditions, seasonal situations where, for example, there are floods, and then the movements of population that really have to be constantly on the move. These are also difficult to monitor, to track, and then to reach. And in the case of COVID-19, for example, the second doses were really difficult to make sure that those people would access these doses before the J&J vaccine became available, for example. Some countries are also reporting as the barrier the effects of xenophobia and discrimination. Some host communities, host population thinking that the migrant, the mobile population are the ones bringing the diseases among them. And then what we have learned really during this pandemic is the need to emphasize further on bottom-up approaches, really learning from the ground, learning from the context, learning from the beneficiaries, the target populations, and really tailor any guidance and strategies or plans to the reality, as well as the different messages that we share to really change the narrative and adapt them to the reality and the context, and have the right communication tools with us to make sure that we achieve the right results. Because these communication we've seen, when movements were restricted, where travels were completely banned, where people were confined, we've seen communication as being critical to achieve any kind of results and to have an impact. Also, there is a real need to adapt to the actual situations in the field and its evolving nature, and manage to revise, replan, readapt as quickly as the situation changes. Also, there is the need to clearly categorize, to clearly mention, to clearly identify the right populations in the plan, include migrants and other vulnerable populations from the start in the different national strategies and plan, to ensure that the related interventions do incorporate them and then they do target them. In theory, yes, of course, but more in practice, which was the main gap that we've seen throughout the pandemic. And lastly, we also learned that there is a need to support the health sector. As IOM, we are really supporting with our expertise in multi-sectoral engagements and collaboration to define roles and responsibilities of the different sectors, but really upfront, and then negotiate at the right level for the consideration of migrants, of displaced population, but also refugees, and making sure, again, that their rights to health and protection is respected and applied. Thank you.
Thank you. I mean, you've really, laid out a view of the challenges that go from governments really not wanting to put up the resources or sort of manage the finances around addressing the health needs of displaced or migrant populations, to legal considerations, requirements of nationality or residency, but also just some of the logistical hurdles around maneuvering in a new language or a new context, and of course the fear and just uncertainty about linkages between health authorities and migration and some kinds of enforcement. So really a very complicated situation that, it sounds like has become even more complicated in some ways because of the intensity of the pandemic over the past few years. Cathy, I want to turn to you. Both Rebecca and Mireille have laid out many of the challenges that different populations have faced over the course, even before the pandemic, and then, of course, really with the move toward COVID-19 vaccines during the pandemic and the need to sustain programs, routine programs that had been in place. I wanted to ask you to say a bit about PATH's work during this period, in particular, looking at the challenge of reaching adolescents. I mean, we know that coverage rates for HPV vaccine have fallen off after successful rollouts in many cases over the previous decade. I wonder if you could say a little bit about reaching adolescents during this period, and also what it's been like as you've seen programs kind of struggle to expand to reach out to adults who in many places are not often the targets of immunization outreach in the same way that families and children are, as Rebecca was mentioning earlier. What has it been like for some of the programs you work with to begin to reach out to adults to try to incorporate vaccinations for that older age group into the system? If you could say a bit about what PATH is learning during this period.
Sure. Thank you, Catherine, and hello, everyone. I think one vaccine I can clearly talk about is the HPV vaccine, which targets adolescent girls aged 9 to 14. So the HPV vaccine, as you may know already, prevents cervical cancer. It can save thousands of lives. And during the pandemic, there was, so the pandemic really affected at different levels. First of all, there was a shift in the focus of the EPI programs. It was really hard to get their attention during the pandemic to work on the HPV introduction activities because there was so much to be done for COVID vaccination, like applying for funding, training health workers. It was just a lot of work for them. And then HPV was not a priority at that time. There was also a shift in resources. So most of the financial resources were, again, shifted towards COVID vaccination. Because there's a contribution, Gavi, of course, pays a good part of the resources needed for the HPV vaccine introduction, but there was also a contribution from the government that we couldn't get at the time because, again, COVID was around, COVID was the priority. So, and lastly, there was also a shift in strategy. So the most effective strategy when introducing the HPV vaccine is the school-based strategy. So, for example, in Senegal, 80% of the girls are vaccinated in schools. Most of them are in primary school, actually. But during the pandemic, schools were closed. We were not able to reach girls through that strategy. We had to shift and be innovative, see how we can do these activities differently. So we had to go towards the community, find the girls in their homes, organize intensification of vaccination during a week or two to try and reach girls who were in schools or out of school during the pandemic. I think also a very important point was communication. When we were vaccinating during COVID, for example, in Mauritania, people were skeptical. They thought that it was the new COVID vaccine and there were lots of rumors about it around the vaccine. They did not want to get vaccinated. So last April, when I was in Mauritania, it was in April. So we had to, we didn't have a lot of communication activities. Coverage was really low, about 44%, which is considered low when it comes to HPV in general, any other vaccines too. But a year later, like 2 months ago, we had a second campaign. We said, okay, this time we'll really communicate around the vaccine and, all the rumors and misinformation, as Rebecca and Mireille mentioned earlier, we had to tackle those. And we saw a big difference. We went from 44% to close to 90% coverage just by really communicating about the safety of the vaccine and its efficacy and how we can prevent cervical cancer. So I think for adolescents, even before the pandemic, they were hard to reach. They were hard to reach because they are not the usual target for routine immunization. So we had to go do extra efforts in general to reach them, but even more so during the pandemic right now. And countries were affected at different levels. So countries who were preparing to introduce the vaccine had to stop. Countries who had already introduced the vaccine had to rethink the programs, find new strategies. So the impact of COVID was, as you said earlier, really seen in the field and in terms of coverage. But I think what we can learn from HPV vaccination and apply to other vaccines when it comes to adult vaccination, like let's say COVID vaccination, I think is the fact that the strategy is mobile. We have to go towards the community. We cannot wait for them to come. I think for HPV, it's a lessons learned. We said, okay, if we wait for girls to come to the health facilities, we won't reach them. So let's go towards them. Let's go to the schools. Let's go to the community. I think for COVID vaccination, also we saw that in DRC, it also worked. Mobile teams were going to strategic places in the city, high traffic areas, and offering the vaccine for those who couldn't go to the health facilities. And I think we saw the results. It was the most effective one. Thank you. Over.
So it strikes me, I mean, all of you in different ways have really focused on the challenge of trust and really tailoring strategies for outreach to conditions at the local level, really talking to people, understanding what their needs are, and focusing on developing a strategy that will meet those needs. And you know, what's really become clear over the course of the pandemic as well, you know, I think is the importance of delivering those health services within the primary healthcare framework, with care really being people-centered and delivered, you know, building that trust and delivering that care by trusted people at the local, you know, at the community level. So Rebecca, I wanted to go back to you for a second and just to ask you to say a bit about how the programs or the projects that you're involved with define PHC, you know, define primary health care. And how important do you see the PHC model or framework for delivering immunization services? And what, can you say a little bit more about what's gained, you know, kind of beyond some of the gender-related issues you were talking about, what's gained by, you know, really focusing on community engagement and delivering those services at the community level?
Yeah, absolutely. Thank you so much for that. Well, I think for starters, I just want to note that despite the circumstances that we're in right now with COVID vaccination, where some very unusual strategies have been used, you know, the mass campaigns at stadiums in some instances, things like that, by and large, immunization is a cornerstone of primary health care. You know, it's always been a cornerstone of primary health care. It plays out differently for certain diseases, perhaps vaccine preventable diseases such as polio and measles at different points in time, but it really is a cornerstone of primary health care. And one of the really important attributes of childhood vaccination is that we are trying to reach every single child. This is particularly prominent in the current environment, policy environment, with the emphasis on trying to reach zero-dose children. And I think we've come to recognize just how critical it is to try new and different approaches, but also expand some of those approaches that have worked over the past several years to get coverage to the point where it was, at least prior to the pandemic. We're trying to reach every child. And one way that not just those who come to the health facility, you know, and as Cathy was just saying, we need to make sure that those services are made convenient and available to those who are expected to use them. So we are trying to reach every child. And one of the most powerful tools that we have for enabling that process is something called micro-planning. This is a really quite a detailed process that happens at health facility level, or it happens maybe a level up within the health system, to really try to identify where are people. Where are they located? How can we get services to them in a way that meets their needs? And what are the resources that are required to do so? So as we're thinking about that, we're applying that now for COVID vaccination as well. I mean, again, it was originated for childhood vaccination, but we're certainly seeing that it's highly applicable for COVID vaccination. So here's the thing, if we're trying to do micro-planning to reach every child, we have to recognize that every child is born to a woman who needs other services. She needs antenatal care. She needs safe delivery care. She needs postpartum care. She needs access for her family for other aspects of primary health care. And so what we've been seeing is that process, that approach of microplanning, excuse me, with some adaptation can be highly useful for serving other health interventions within primary health care as well. I think one of the other things that we've come to realize is just thinking about how immunization is embedded within primary health care is, we have new vaccines that have been introduced over the course of the past several years or are going to be introduced in the years to come. Cathy was just mentioning HPV vaccine. And what we see with some of these vaccines is that they are extremely powerful tools, but they are just one tool in a toolkit. So for example, with rotavirus vaccine is highly effective in preventing a certain type of diarrheal disease. But we have to look at how to prevent and manage diarrheal disease in a broader sense, recognizing that, again, the vaccine is one very important tool, but it needs to be used together with other tools. The same is true with the very exciting developments around RTSS vaccine for malaria. This is a fantastic development. It holds great promise. It's going to be able to reach people who may not have access to other interventions for malaria, and that has been demonstrated. But we also recognize that it is one tool for malaria prevention and control that has to be used in conjunction with other tools that are part of that primary health care model overall. Just going back for a minute to microplanning. One of the things that we've really seen over the years and which we see right now in our work under MRIGHT in Mozambique and in DRC and in Kenya is how important it is to have community engagement, active community engagement as part of microplanning. This is the way of ensuring that the plans that are developed actually capture the needs of those clients who are to be served and reached with vaccination services. They are the ones who can provide the input as to what time of day to provide the services and where exactly to provide them. Is it okay to do it in a school during certain times? Is it okay to do it in to provide outreach services in a church as opposed to a mosque? I mean, again, this has highly contextual aspects to it for which the community voices are really critical. And I just want to mention that back several years ago at JSI, we conducted a series of studies to try to understand what is it that drives improvements in routine immunization, childhood immunization, this was at the time. And in our analyses in Ethiopia, Cameroon, and Ghana, what we found was that we identified about 6 drivers, and really about half of them clustered around building strong partnerships between health systems and communities so that people see themselves as being on the same page and working towards the same goal. Immunization is relatively countable. It's relatively a constant kind of primary healthcare service. It's tangible. People understand the value of it. And that's where we found that really forging those links between health system personnel, whether it's frontline health workers or their supervisors, and those representatives from the communities, and of course the mothers themselves, is critically important for figuring out where, when, and how to provide those services in a way that is mutually agreeable, and which also brings in some mutual accountability. Communities have their own contributions that they can make to help enable things like outreach to happen. And finally, the last point I just want to bring up is often missed or not fully recognized is how important and powerful it can be to bring in local non-health actors within the local government, that is to say, outside of the health system, but operating at the local level of government. General assemblymen, local political figures, local civil authorities who make budget allocation decisions. They have critically important roles to play, but only if they know that they have those roles to play around immunization. Typically in immunization, we haven't done a great job in reaching out to them. And some of our prior work under a previous USAID-funded project called the Maternal and Child Survival Program, we did quite a bit of work in Uganda to really try to bring the health personnel together with those local non-health actors, with some very tangible outcomes from those collaborations. And just to mention one example, in one particular district, in Bulambuli district in Uganda, where about half of the population had not been vaccinated at all, by bringing those local non-health actors into the micro-planning process, they became aware of the fact that about a third of the population did not have physical access to immunization or primary health care services overall. There were no health facilities nearby. And as a result of their involvement in that micro-planning process, they charged other officials, other administrators, to repurpose 6 buildings, government buildings, as health facilities, primary health care facilities that were then staffed and equipped. And that led to a doubling of the number of villages that could be served, not just with immunization, but with other primary healthcare services, from about 340 to almost 700 villages that then could be reached. And it was because of that reaching out, not regarding immunization as its own standalone program, but really situating it very well within within primary healthcare overall. This is exactly what we're trying to do now with MRIGHT in our country programs, particularly in Mozambique and in DRC, as Cathy knows so well, and in Kenya, trying to ensure that we really recognize the opportunities for integrating immunization, service delivery, and other management functions within primary healthcare more broadly for the mutual benefit, not just of immunization, but for other services, other primary healthcare services as well. Thank you.
So, Mireille, Rebecca has really emphasized the importance of embedding immunizations in a primary healthcare model. Within a community where you can bring in elected officials or known civil authorities and other leaders, which strikes and really engage in a level of micro-planning with the community to determine needs and design strategies. But it strikes me that in talking about mobile populations that may have relocated from one place to another, whether within a country or between countries, and particularly if moving because of political issues or conflict, that building that sense of community and creating that sense of trust that would allow for the kinds of engagements and planning that Rebecca has described may be slightly more challenging. And so I wanted to ask you to talk a little bit about what it takes to kind of build those relationships of trust and community around health and around immunizations within migrant communities, and really how can some of these lessons about people-centered, locally rooted health services be applied within the context of serving migrant populations?
Thank you, Catherine. I guess building trust requires really to be able to address multiple factors and needs. And this is exactly the same for migrants and the host communities, to ensure that we really create an atmosphere that make them feel really in a safe environment that we could navigate in and interact with them in. So these are related, I would start by saying that these are related by knowing your audience, first of all. Wherever they are, you need to know who you're talking to, right? So while referring to migrants, IDPs, and refugees in general, maybe as vulnerable populations or groups, within these, you also have specific groups with different type of vulnerabilities, but also needs that are present. So I'm talking about children, women, adolescent girls, for example, people living with disabilities, with HIV or other diseases. These are all examples again. And those targets, those groups do have specific and targeted needs and do different attentions that you have to really apply, as well as the related sensitivities and discretions that you might need when you address the different groups. So first of all, really to create that environment by knowing your audience, then to know the environment these populations do evolving, do move through the different mobile path that they have to follow, depending on where they're coming from, the reason why they have to move, they had to leave their homes, all the legal implications also of interacting with the different populations, as I mentioned earlier, that could be related to fear of being deported, of being returned to their homes. So all these have to be factored in, to be taken into account, as well as the different access issues that we also mentioned through the different barriers and limiting factors. And these are to be also considered in the different messages and interventions that we do throughout building this trust with those communities. We need to know the different communication tools and channels that we can use with the audience, but also what kind of information we could share, and as well as the social behavior challenges, such as the language. So as Rebecca was mentioning, to really involve the right people together with us, people that are part of the community, that would know the language, but also know the level of literacy of those people, whether or not they have access to the different media, information, and then practices and norms when it comes to social and behavioral areas. So this also, again, I will also reiterate the point and emphasize on the need to really involve the different influencers, the different community leaders, but the different people that could, like religious leaders as well, anybody that could really help create that link with the target audience, and then with the population. Among a group, we've seen in different area, in different gathering, in different context, even among a group of people that had to flee, among a group of people that had to really leave their homes because of war, you will always find a leader, someone who is really leading the group. So you really need to identify that person and address the communication, address the needs through that person that people will really follow and they really trust already. Also, we need to know their fears and how these could be addressed, how this could be really taken into account in the different intervention, but in the answers also that we give to them, and also point of clarifications for the stigmas and discrimination that they're also facing, how we can really help them overcome these, how we could really create that safe environment that I was speaking about, and avoid community rumors or myths or misconceptions to really evolve and expand further by really trying to help them throughout the whole process. All of these are definitely done and in knowing also the host communities. So we know the migrant, we know the mobile population, but we need to know also the host communities as well, which may also in some instances, face similar challenges and barriers, and who can jointly benefit from the related interventions, which is also creating some sort of synergies among them, and then inter-ethnic or intercultural tolerance and understanding of each other's. I would say, and also I think Cathy, she raised a very critical point of the need to really be close to the community, close to the population, really avoid having only general standardized approaches or maybe centralized, but really go to the lowest levels and be part of the community. I've seen an example from recent intervention, recent field missions. In Nigeria, for example, we went to the northeast, Maiduguri and Monguno, where we really had to go through to the IDP camps and really be part of the population. We first of all, as I mentioned, identify the community leader, the camp leader, I will say, someone who could really translate what we were doing. But we had also among the host community someone who knew the language, and we were communicating in their language, even using myself some of the the words that I managed to learn to really approach those population, talk about vaccination in their own language, in the way they could understand it, but also any other health, essential health intervention that they could benefit from. And that same day, we've really seen an increase also in vaccine uptake. In that case, that was the campaign for COVID-19 vaccination. And I would say 95% of the camp eligible population were vaccinated that same day, just after the intervention, and really to the conversation that we've had together. Same with DRC, as Cathy also mentioned, by really going down to the community and having involved the community leaders, but also community actors, community youth, who would talk to their population, but also around their communities, and will make them understand the benefit of vaccination, but the benefit also of accessing healthcare services. Really helped also in our case, because we are present in most of the priority point of entries. This has helped also with the vaccine acceptance and the vaccine uptake at that moment. And using all these strategies, all these experience, all these lessons, we use that as part of our risk communication and community engagement strategy to help us really navigate through the difficult barriers that the community are facing. And this helps us really to build community trust, to reduce hesitancy, which is fairly high, but ultimately improve vaccine uptake among migrants and vulnerable population. Also, to mention the need and to also emphasize on the need to really integrate also the different interventions and services who would really help to make population accept the vaccine and really go for vaccination. Because now we're really in some part of the world really lightening, I would say, the related measures to COVID-19, for example, and going back to what we call the normal times, and where routine immunization will literally be recover from the impact that it has had during the pandemic. But then other countries are still facing very low coverage of COVID-19 vaccine, but very, very extremely high hesitance. So the need to really integrate messages for people with different health priorities is very key there as well, and important. Thank you.
Thank you. So Cathy, I want to turn to you for a second. You know, both Rebecca and Mireille have emphasized the importance of tailored strategies, micro-planning, you know, really the kind of outreach to the community that can help understand the needs and deliver the best services. And of course, a lot of this effort linking with the community relies on community health workers. But we know that over the course of the pandemic, health workers have experienced multiple burdens. They themselves have faced illness, lack of personal protective equipment. They've seen colleagues become sick and die, and you know, they've had to take care of their families at the same time that they're working in health centers. And there's there have been numerous reports of burnout and just mental stress and fatigue on the part of health workers and community health workers in particular. So I just wanted to ask you to say a little bit about the role of community health workers in ensuring equitable immunization services, and in addressing some of the rumors and misinformation and some of the challenges that Rebecca and Mireille have talked about, and really what more can be done to support community health workers who are facing so many of these different burdens, and yet upon whom so much is really depending for the success of these programs.
Mm-hmm. Yes, thank you, Catherine. I think all of us will agree that community health workers are essential when it comes to immunization for the planning and implementation of activities. They contribute in the, as I said, planning, micro-planning, as Rebecca mentioned earlier. They work closely with the EPI programs before even the vaccination starts. Before vaccination starts also, they help identify the target groups. They are the best positioned person in the community to know where the for when it comes to HPV, where the adolescent girls live, when it comes to routine immunization for infants also, they know the parents. They are the best place to help us identify and vaccinate target groups. For HPV vaccine also, we need, for example, two doses. Tracking the girls is quite challenging, but with the help of community health workers, it was feasible to find the girls 6 months later, 1 year later, and give them the vaccine. So in general, for me, for all types of vaccines, it is essential to work with them. They do a great work. And the question now is what you ask, how can we improve their contribution? How can we give them the tools they need to do better? I think that's a great question. I wouldn't say that we have the answers yet, because the thing is, they work not only on immunization immunization activities, but they also do malaria work. They do nutrition work. So it's a lot of programs that rely a lot on community health workers. I think what we could do is sit together and talk together how we can strengthen their role and give them the tools they need. Because the thing is, by definition, community health workers are volunteers. So even when some programs are tempted to pay them, people are reticent. They say, okay, let's think about this carefully. Can we give them money? Should we not? So there was a lot of discussion around it. We haven't found the right solution. But what we can do at least is give them incentives. Sometimes they don't ask for much, just like a raincoat for when it rains or boots, just to walk around the community will suffice. So we can probably continue the conversation, continue thinking about how to do it, but we know for sure that the success of many programs, and we need to hello?
I think we lost you for a second, but
oh, sorry. Can you hear me now?
Yes.
Okay.
So.
Where did you? Oh, I had finished. Where did I stop? Where did you stop hearing me?
I think you were just emphasizing the ways that we can identify support for community health workers.
Yes.
In future.
Okay.
So.
Yeah, sorry, I didn't know where I got cut off, but I was just saying, yes, we need to find ways to support the community health workers by giving them incentives, even if they are not paid monthly, but we can probably find tools like just giving them a raincoat for when it rains or boots to walk around the community, maybe a good start until we find a consensus between all the partners on how to compensate these people for their work. Thank you.
Thank you. So we're coming to the end of our session, and this has been a really rich discussion with a lot of important points raised, and I know we could take each one of these points and have a future discussion around each one of them. But I just want to ask each of you in just the short time that remains for us to offer some final reflections on lessons from the pandemic that your organization has really learned over the past 2 years in particular. And steps, just if you would kind of identify one priority step that you think local, depending on your perspective, your local organization, the development assistance programs or multilateral agency can take to really strengthen the delivery of immunizations across countries but really across the life cycle, across the life course, just lessons from the pandemic and really one step that can be taken today to increase the awareness and reach across the life course to improve equity within the populations with which you work. So let's see, Mireille, let me start with you.
Thank you again, Katherine, and thank you, everyone. I think what we really need to continue doing is to join forces, something that we really learned to do further during the pandemic, and strengthen really the stakeholders' collaboration and coordination at all levels. I'm thinking about the health sector, definitely, but also with other sectors that we've seen that we really need their involvement if we want to achieve better results. And something that I think we should take immediately as a first step is to really contextualize our different interventions, but also strategies, and have them really built, developed, and shaped at the subnational levels, really like targeting subnational levels and the right context and the field situation as it is. I think this is my main take for, and definitely from our area of work, for our mandate, but also expertise, would be to have from the very start of all these interventions, all these strategies, to have all type of populations included in the plans from the very beginning. Thank you.
All right, thank you. So multi-sectoral engagement and really collaboration across many different fields within the health sector and beyond. Let's see, Cathy, let me turn to you. What's your top priority or recommendation?
Recommendation, in addition to what Mireille said, I think reducing vaccine hesitancy is really important. I think when it comes to at least the vaccines I know most, the HP vaccine and the COVID vaccine, vaccine hesitancy plays a big role. So, and second, improve accessibility of services. How do we make vaccination services more mobile, closer to the community? I think that's a major barrier that if we can address, we will get better results. And finally, as you mentioned, community health workers, how do we support them to better do the work they are doing? They are essential to get also better results. Thank you. Mm-hmm.
Thank you. So better address vaccine hesitancy, improve accessibility, and continue to support community health workers. Mm-hmm. All right, Rebecca, the last word is yours.
Okay, thanks. So first, I want to say how much I agree with the points that Mireille and Cathy have just raised. Really critical points. I would say that the pandemic has forced us, in a way, into life course vaccination in a way that previously had been stalled, frankly. And with this attention to life course vaccination, we have some opportunities here. We've got lessons that we are learning in real time right this minute. One of them is about new types of partnerships, reaching out to different types of people that we haven't worked with previously, professional associations, other organizations, employers, and so forth. And we've also come to realize that we have new points of entry for immunization, for example, through HIV/AIDS programs in Southern and Eastern Africa, where we've seen those programs as an opportunity for reaching people with comorbidities and who are immunocompromised, to reach them with vaccination. The other point, just getting back to what Cathy was saying, is the issue of vaccine hesitance has become front and center in terms of attention. And with that concern has come the rapid implementation of better methods and tools and an acceleration of work to understand the reasons for low vaccination uptake. We've got new tools and models that have proven to be very, very effective that we need to continue using, because the issue of vaccine hesitance, as well as its counterpoint, vaccine acceptance, which is what we're after, is going to continue to be an issue in perpetuity. Finally, I would say that we are seeing enhanced use of data across the board to try to figure out where and how to provide those kinds of tailored services and strategies that both Mireille and Cathy were just talking about. Those are all some gains that we have made during this very, very difficult period of the pandemic that we certainly should build upon and not lose what we've learned from them. Thank you.
Great, well, thank you. So new partnerships, better integration with other areas of health services and other social services, and really better use of data to target populations and understand the kind of outreach that's needed. I want to thank the three of you for taking the time to join me today to share your perspective on the state of global immunization programs and what it takes difficult to reach populations and to reach populations really at all different ages, whether they be migrants and refugees, adolescent girls, or people living in remote or just underserved communities, maybe in urban centers. I also want to thank Mackenzie Burke and McLean Spear and the AV staff here at CSIS for their work in putting this live stream together today. And I also want to thank you, the audience, for joining this session and wish everyone a good remainder of World Immunization Week. Thank you all very much.
Welcome to CSIS Online, the way we bring you events